of this test, so I definitely recommend spending time with that. But on that note, let's go ahead and we'll get started with the review, okay? So remember we first started talking about anatomy and the physiology of the cardiovascular system. And we talked about the anatomy of the pericardium, how there's those two layers. There's a little bit of fluid in there. And the main roles of the pericardium is actually to maintain location of the heart, to prevent that extreme dilation of the heart, and then serve as a barrier from infection. Then we talked about the layers of the heart, how you have the epicardium, which is actually contiguous with the visceral layer of the pericardium, so they're one and the same. Then you have the myocardium, which is your muscle layer, and then the endocardium, which is the innermost layer. And we talked about how the myocardium actually has two components. It's got the contractile portion, so the muscle itself, but then we talked about how it has the non-contractile components, which are things like the conductive pathways, things that regulate the function of the muscle layers themselves. Then we talked about how you have the endocardium, which is a barrier between the blood and the tissue. And we talked about how this lines all of the structures inside the heart to include capillary muscles, the valves themselves, and even into the blood vessels. And that's important because understanding that where all that layer is can help you understand when you have a patient with infective endocarditis, where you can expect or where it's possible for you to have this vegetation and this infection. Then we started talking a little bit about physiology, and we talked about how with the physiology of the heart, you have a lot of regulation. Sorry, I've got a thing saying it's powering down the system here, which includes the mic. So
someone came in before you and fixed it, so it should be better.
Give me a please wait while the system powers down here, Sarah, so it's not going to be until it powers down.
Oh, yeah. Yeah, I get it.
Is he free for y'all Sunday morning? What y'all do?
Okay, I think we're back in action.
Now we have to do a soap night.
I swear, all I wanted to do was increase the volume on the mic and shut everything down. Okay, so we were talking about the cardiovascular system is tightly regulated. You get a lot of inputs to regulate its function so that the rest of the body can ensure it's getting the supply of blood, nutrients, oxygen that it needs. And there's a couple of mechanisms that the body uses in order to regulate the function of the heart. The one is the Bainbridge reflex, which is a response to atrial stretch. So as you're increasing preload, that stretch of the atria will then trigger the heart rate to increase, and it's because of that increased vascular return. So you're increasing your preload. I got to increase my stroke volume, my cardiac output, so that that increasing preload doesn't overwhelm the heart.
Sir, what's the difference between this and Frank Starling?
Frank Starling, kind of think of that more of a ventricular kind of thing.
Atrial versus
Correct. Yep. But this can lead to Frank Starling issues if we don't increase that cardiac output by increasing the heart rate. So, because with Frank Starling also, it's actually increasing more like the contractility. This is increasing heart rate. So you're kind of manipulating a different factor to increase that cardiac output.
So we are aiming to increase the preload and afterload?
You're trying to, in the Bainbridge, you're trying to decrease that preload to a manageable level, because what's happening is you're increasing that venous return, it's stretching the atria out, and if I don't do anything to kind of deal with that extra load coming in, that extra preload, then it's going to start backing up, and then you're going to start having peripheral congestion and all those types of things like you get in heart failure. So what Bainbridge reflux will do is it senses that it's increasing that stretch on the atria because of that increased preload, that it's going to trigger the heart rate to increase to kind of get rid of that extra volume. Does that make sense? Okay. Then just your breathing pattern actually influences or affects the function of the heart. When you take a deep breath in, you create that negative intrathoracic pressure that increases your venous return, and then as you exhale, you then get that positive pressure environment in the chest, and then that will decrease that venous return, but it also will kind of help get that volume out of the heart and into the systemic circulation. But the main way that other systems are going to interact with the heart is the use of the autonomic nervous system, which we know there's the sympathetic side of things, which is your fight or flight response, right? And then you have your parasympathetic, which is your rest and digest. The sympathetic nervous system actually synapses on both the atria and the ventricles, in addition to the SA node and the AV node. And ultimately, what the sympathetic nervous system is going to do is it's going to increase the heart rate, it's going to increase the contractility, so the power of the squeeze, and it's going to increase how fast that conduction from the SA node to the AV node down to the His-Purkinje system will be. So it will speed things up in an effort to speed up the heart rate, increase that cardiac output, stroke volume, and all those things. Parasympathetic via the vagus nerve synapses only on the atria, the SA node, and the AV node. It does not synapse on the ventricle. And its purpose is to slow things down. So it slows down the heart rate, it slows down the conduction of the action potential, and then it also, in the atria, it decreases the contractility a little bit, okay? But it doesn't do anything to the ventricle, so it doesn't decrease contractility of the ventricle, okay? So that's a key kind of difference between the parasympathetic and the sympathetic. Then we talked about how in the cardiac muscle itself, the electrolytes that are important for function is sodium, calcium, and potassium. So you have three things for muscle contraction that's important. But when it comes to the conductive pathways, so the the path that goes from the the SA to the AV node, and then the His-Purkinje system itself, these don't rely heavily on sodium, and instead rely on calcium and potassium. So that is a difference between the conductive pathways versus the muscles of the heart. Then we also talked about how calcium is actually vitally important for the actual contraction of the muscle. So important that there's actually the sarcoplasmic reticulum, which is kind of a structure that holds on and kind of serves as a reservoir for calcium in order to help with muscle contraction. Okay, so calcium is vital for the function of the heart. And we talked about the reason it's vital is because calcium will bind to that troponin on the actin fibers so that it will expose the myosin binding site, and myosin and actin can interact with each other, and then it can do its little power flex move and contract the muscle fiber, okay? Then we went on and we started talking about how blood circulates through the heart. We talked about how you have deoxygenated blood that returns to the right atrium, and then during diastole, it's going to go through the tricuspid valve into the right ventricle. And you're going to have, at the end of diastole, that atrial kick or that atrial squeeze, which will just increase the volume of blood in the ventricle, in the right ventricle, to maximize that preload. Okay. Then, now all that blood is in the ventricle, the atria has finished contracting, it's now turned for the ventricle to contract and start systole. And you get the squeezing of the right ventricle still containing deoxygenated blood, and it will squeeze and send the blood past the pulmonic valve and into the pulmonary arteries and into the lungs. It becomes oxygenated and then comes back to the left atria, and then during diastole, that blood is going to flow from the left atria to the left ventricle through the mitral valve, and then you get that atrial kick again like you did on the right side, and now you have oxygenated blood ready to go in that left ventricle to be squeezed out during systole through the aortic valve and into the systemic arterial system. This is where that preload is converted to your afterload, okay? But then we looked at the structures of the valves themselves, and we talked about the atrioventricular valves, so the valves between the atria and the ventricles, which is your tricuspid and your mitral valve. And we talked about how these are open during diastole, they're closed during systole, or should be closed during systole. And we talked about how there is a difference between the tricuspid, 3, and the mitral, which is also known as the bicuspid, 2. So tricuspid has 3 valve leaflets, and the mitral valve has 2 valve leaflets. Then we talked about the semilunar valves. We talked about how you have the pulmonic valve, which is the outflow of the right ventricle, and you have the aortic valve, which is the outflow of the left ventricle. But we talked also about how the aortic valve is important because just above the valve is actually where the ostia are, the start of the coronary arteries are located. So if you have anything that disrupts blood flow in that area, then you are going to disrupt blood flow into the coronary arteries. Then we talked about papillary muscles, and we talked about how these are kind of act like the risers on your parachutes, where this kind of gives a counter resistance to your atrioventricular valves so that those leaflets with a high pressure in systole don't excessively go back into the atria and you get a regurgitation. Okay? So these muscles kind of give that counter pull to maintain that integrity of that one directional valve. Then we talked about the coronary arteries themselves. We talked about how this occurs during diastole, or the perfusion of the coronary arteries occurs during diastole. And we talked about how it's important that it's during diastole, one, because those holes, those ostia, may be blocked with the valve leaflets of the aortic valve during systole when it's open, right? So now you're having disrupted blood flow to them. But 2, the other reason it's important that perfusion is during diastole is because the myocardium is squeezing during systole. It's going to squeeze and close those small arteries. So you're not going to get perfusion through the coronary arteries, or at least not an adequate perfusion during through the coronary arteries if that perfusion were to occur during systole. Okay? So it's important to know that this occurs during diastole. It's also important to know when we are talking about different pathologies, especially when we're talking about like arrhythmias, fast heart rates, and those kind of things, where it decreases that diastolic filling time, that it actually is also decreasing the perfusion of the coronary arteries. So it's more than just the heart rate's fast and the oxygen demand goes up. We also are decreasing the oxygen supply at the same time. So you can see that difference between supply and demand can get simply worse if you're not allowing the perfusion of the coronary arteries. But then we talked about the main coronary arteries, and we talked about the different structures that they perfuse. And we also talked about that if you have a disruption of blood flow in that artery, what are maybe the possible complications that could develop? So we talked about the left anterior descending does the bulk of your left ventricle. So if you knock out the entire perfusion of the left anterior descending, then the left ventricle stops working, or the majority of the left ventricle stops working. And think about the complications or consequences of what that would be if that were knocked out. And that's why it's also known as the widowmaker, because you probably are going to die with a complete occlusion of the LED. With the circumflex, you get the lateral portions, kind of the big thing, but in 25% of individuals, perfusion of the SA node is from the circumflex. So if you're one of those 25%, then if you knock out the circumflex, then your SA node stops working. Okay? And think about the implications of having that SA node dead. Then we talked about the right coronary. We talked about how this does the right ventricle itself. We talked about how it does the inferior wall. It does a lot of the posterior wall. But it does a lot of important other structures, like the SA node in the majority of patients, like 75%. It does the AV node in a large portion of our patients. So if you have an occlusion of the right coronary, you're going to be knocking out some very important structures of the conductive pathway. Then we talked about the posterior descending, how this is kind of both the circumflex and the right coronary kind of work together to get the posterior wall. But that could present some problems if perfusion were blocked in this region as well. Then we went in and we started talking about physiology, and we started talking about how cardiac output is really the functional measurement of the heart. And we talked about mathematically the way we calculate cardiac output is you take the stroke volume, so how much blood was ejected during systole, and you multiply that by heart rate. So that way you can get a milliliters per minute equation. And we talked about how the factors that go and influence that stroke volume component can be things like your preload. So how much blood do you have at the beginning of systole to be able to eject out of the heart? Do I have 10 milliliters or do I have 1 milliliter? If I don't have the volume there to get rid of, then it's going to impact my stroke volume. Then we talked about the contractility, where now you're talking about the power of the squeeze. So how much of that blood volume am I going to squeeze out of the heart each time the muscle squeezes? And that's important because if I have a more powerful squeeze and now I'm ejecting 70% of blood versus I have a very weak heart and my squeeze is very weak and I'm only doing 10% of the blood there. You can imagine the difference in the volume of blood getting out of the heart simply from that. And then we also talked about how afterload actually has an inverse relationship where the higher the afterload, it actually decreases your stroke volume because you're having to work harder to get blood out of the heart. Okay, so too much afterload is a bad thing and will decrease your stroke volume. Preload, by definition, is what is the end diastolic volume. Also, you can talk about it in context of pressure. So what's the end diastolic volume or the end diastolic pressure? And that gives you the availability of blood to leave the heart during systole. And we talked about what makes, or the factors that make a preload is how much blood is coming back to the heart in the first place. Your atrial contraction, because about 70-75% of the volume of blood comes during a passive phase during diastole, but 25, maybe 30% of the volume of blood actually comes from the atrial squeeze or that atrial kick. So I need that atrial contraction to increase my volume. If I have a condition like atrial fibrillation and I'm not getting that atrial kick, that's going to diminish the amount of volume I have to get out of the heart. Then you have resistance from valve. So if there is any kind of resistance, like a stenosis, then that's going to cause me to have to exert more effort to get blood circulating. And then how willing is that ventricle to dilate to accept all of that volume? And then the last factor that affects preload is your heart rate. And this is not the heart rate component that goes into calculating your cardiac output. The heart rate is really looking at the diastolic filling time. If I have a slow heart rate, I have a longer diastolic filling time, so I can get more preload into the ventricle. Okay, so think of the heart rate component of preload as a how much time during diastole do I have. Then we talked about myocardial contractility. That's how powerful the squeeze is. We talked about how there's medications that we can give that will increase that squeeze in a diseased heart. But we also have things that can actually decrease the squeeze. So if you have a patient who already struggles with heart failure and they're getting ready to go to, say, like a malaria endemic area, we may need to think about the medications we give them because maybe we're going to give them something that's going to precipitate a heart failure exacerbation because we're decreasing that contractility, okay? Then we talk about afterload, and the afterload concept comes from Laplace law, but don't memorize this. Basically, afterload in a clinical setting can basically just come down to ventricular pressure, or a systemic arterial pressure. Okay. So, what is the pressure in the pulmonary artery? What is the pressure in the aorta and the systemic arterials arteries? That is your afterload. Okay. And the things that can affect the afterload is what's the systemic vascular resistance? So what is that tone of those vessels? What is the aortic pressure, pulmonic pressure? And then is there any evidence of valvular diseases? So this could be aortic pulmonic stenosis, where there's that resistance to opening and the resistance to getting flow. It could also be tricuspid and mitral regurgitation, where now path of least resistance is to go back to the atria as opposed to going out into the pulmonary arteries or to the aortic or to the aorta, depending on which side you're talking about. But those things can play into your afterload or affect your afterload. Then we also talked about how cardiac output is the true measure of function of the heart, but it's hard to get exact measurements of cardiac output without having to do invasive monitoring. So the way that we clinically can assess the function of the heart is with ejection fraction, which is an estimation. And basically, we're just looking at what's the percentage of blood that was there during systole gets sent out of the heart. Okay. So the way you calculate it is your EF is your stroke volume divided by your end diastolic volume. Okay. And there's another way to kind of break that down, but the simple math is how much blood left divided by how much you had to begin with, okay? And it gives you that percentage there. And that's something that we can calculate in non-invasive means, which most common way is echocardiogram. But if we wanted a kind of the gold standard, we would need to do a cardiac catheterization, but that comes with a lot of risk, so we just stick with the non-invasive approach using echo. And then the mathematical equations kind of break down into this. And then kind of moving on, we talked about the pressure volume loops that are present in a normal cardiac cycle. And we talked about how each of the factors that affect stroke volume, how they change that pressure volume loop. And we talked about how if I increase my preload, I'm moving that pressure volume loop over to the right, and now I'm adding all this extra work to the function of the heart in that cardiac cycle. We also talked about if I increase my contractility, it moves that pressure volume loop, it kind of makes it wider and taller. So now I am going to squeeze out more volume because I have a more powerful squeeze to maintain a pressure high enough for a longer period of time to keep that aortic valve open. And then finally, we talked about increasing the afterload. It actually shrinks the amount of work of the heart because I now have to get to a much higher pressure in order to open that aortic valve. And unfortunately, that pressure is going to be very difficult to keep high enough, long enough, to have a normal stroke volume. That valve, that aortic valve, is going to close early, so I'm going to have a much higher volume still left in the heart because of that increased afterload. And then we talked about Frank Starling, kind of going to the earlier question, where with Frank Starling, preload, increasing preload will increase your stroke volume to a point. Once you have too much preload, you then actually have diminishing cardiac output because you've stretched those myosin actin filaments too far, and now you're not getting that powerful squeeze. So increasing preload increases stroke volume to a point, and then you start to see a decline in function. And then increasing, like using the sympathetic nervous system to increase contractility, you can see how that will affect your stroke volume as you increase your preload. Questions about lecture one?
So will we need to make those calculations, or would it behoove us to know the calculations for ejection fraction, stroke volume,
Yeah.
and all those?
There will be one question I will tell you. There will be one question on calculating those kinds of things. I'll give you the factors or the numbers, and you just have to calculate them. The math is easy. You probably should be able to do it in your head, but I will let you use a calculator if you so choose. Okay. But there will be a calculation on the test. Yeah.
Say five.
Okay. Then we went in and we started talking about the cardiac exam, and we talked about how the ideas of inspection, palpation, auscultation, those play a role in the cardiovascular system physical exam. And we talked about, from the inspection standpoint, the first thing you want to do is just look at the configuration of the chest. Normally, you have a 2-to-1 ratio where the chest is wider than it is deep. Okay. This is a suitable configuration because it allows the lungs to expand fully, to bring in all that oxygen, but it also allows the heart to do its function while you're breathing. But there's different variations of the chest, and these can impact that function of the cardiovascular system. So, pectus excavatum, excavate, dig a hole, right? Where you have a depressed lower sternum, will kind of distort the normal anatomy and kind of shift the heart one way or the other. It also will interfere with the normal expansion of the lungs and how that might affect the cardiovascular system. Then we talked about pectus carinatum, which is also known as pigeon chest, where now instead of depressing the sternum, now that sternum is actually anteriorly displaced, and now you have a much larger AP diameter from that. So now that expansion of the lungs and stuff like that may not have the same impact on venous return and everything like that, like it did or does in the normal configuration. Then we talked about barrel chest and COPD and how now that AP diameter is distorted. But the difference between this versus pectus carinatum is that now all that extra expansion is being filled by the diseased lungs. Okay. And then scoliosis, depending on how bad it is and everything, that can also distort and affect the venous return, but it can also affect the output through the aorta and through the systemic arteries. We also, in the inspection, started talking about looking at the skin. We talked about peripheral cyanosis, which is like this bluish, purplish kind of appearance. And we talked about peripheral cyanosis is more of a blood flow problem. Okay, so it's just the flow of blood to that area is impacted. And it could be because of a blood clot. It could be because of severe sepsis, and you're not circulating things right. Okay. But when we talk about central cyanosis, and this is a oxygenation problem, okay? So if you see like the lips, the mucosal membranes inside the mouth, the tongue, if you see that purplish, kind of bluish appearance is present to those areas, you should be thinking that this is an oxygenation problem. The blood is not oxygenating normally. Then we talked about pallor and how this could be a sign of anemia just because you don't have enough hemoglobin, the part that makes blood red when it's oxygenated, and how this can actually have some impacts on the heart because it's going to try to overcome that reduced red blood cell by increasing heart rate and increasing your blood pressure, so increasing the perfusion and trying to increase the amount of oxygen exchange occurring with fewer red blood cells. We talked about edema and how if you have the presence of equal bilateral lower extremity edema, be thinking of heart failure, but there are other conditions to be thinking about as well. If it's non-pitting or it's unilateral, be thinking of like lymphedema or maybe even a blood clot. So there's lots of things that can cause edema of the extremities, but if it's equal bilaterally and affecting the gravity-dependent areas, be thinking heart failure. Then we talked about clubbing, which is the distortion of the normal curvature of the fingernail bed, and how in clubbing this is a chronic change. So this is something that's been going on for a long time. It's not something that develops overnight. Okay, so this tells you that there's chronic disease. Then we talked about jugular venous pulsations, and we talked about how basically by looking and analyzing the jugular venous pulsation, we can kind of get a rough idea of what's going on in the right atria. What's the pressures looking like in the right atria? And the way you calculate it is you put the head of the bed down 30, 45 degrees, and then you measure where that pulsation wave is in that jugular vein. And normal jugular venous pulsation is about 6 to 8 centimeters. Okay, it's not considered pathologic, i.e. jugular venous distension, until that is greater than 10 centimeters. Okay, so you get a little wiggle room in that borderline range of 8.1 to 10, where it's not truly pathologic. And we talked about the jugular venous pulsation wave, where your A wave, which is your highest peak, this is your atrial kick. This is right before systole starts, so the very end of diastole. You're going to generate the highest pressure in the atria. that blood volume starts to leave the atria, go to the ventricle. You start to get that atrial relaxation. That pressure starts to drop. Then your tricuspid valve closes. And then the ventricle starts to squeeze. And that squeeze is going to cause that tricuspid valve leaflet to kind of billow a little bit up into the atria, which leads to this C wave right here. Okay, you see it just kind of goes up a little bit. It kind of just stops that descent briefly. But the atria continues to relax, that pressure continues to drop, and that brings us into the X descent right here, which is that atria now is fully relaxed. The blood flow hasn't necessarily started to come back from the peripheral venous system yet, and it gives you into that lowest peak, or lowest descent. And then that volume of blood starts to come back from the peripheral venous system, and that pressure starts to increase in your atria. Okay. Then systole ends with the closure of the aortic and pulmonic valves, but the tricuspid valve remains closed for a brief period of time, and that pressure in the atria is increasing as you're having more and more blood flow coming back to the atria. And once you get to the peak, right before that tricuspid valve opens, you're going to hit that V wave, and then tricuspid valve opens, you start dumping all of that blood into the ventricle, and you'll see that quick drop of pressure into your Y descent, and then that flow, that pressure difference between the ventricle and the atria is going to start to shrink, and you're going to start having less flow, less volume, before you get that atrial kick again, and you get that A wave, okay? So kind of understanding what the different waves and descents are, what they represent is important, because we can understand pathology of the heart based on what the changes are in this pulsation wave. Talk about Kussmaul's sign. We talked about how ordinarily the jugular venous pulsation will drop during inspiration, but in Kussmaul's sign, in conditions that affect the right ventricle, that pressure actually will rise with inspiration, because that ventricle is not going to tolerate all that extra volume coming back from the venous return. We talked about hepatojugular reflex and how you'll see the JVP rise when you push on the liver itself, so pushing on the right upper quadrant, pushing up. You're forcing all that blood volume up to the heart, but if the heart can't tolerate it because it's in a failed state, then that's going to go into the jugular veins and lead to that rise in that jugular venous pulsation. Then we talk about PMI, or the point of maximal impulse, which is basically typically in the fourth or fifth intercostal space, where you're kind of feeling the maximal impulse of the squeeze of the heart. Okay, usually it's at the apex or the mitral auscultation site is where you hear it best. And if you have a condition where, like, the volume, you have too much volume, then that can lead to that PMI starts to move around on you. It's hyperdynamic. In conditions where the pressure is too high, now you have to have a squeeze sustained for a longer period of time in order to get and to fight against that pressure. So you're going to see that the duration of that PMI is going to be longer than normal. Then we talked about thrills, which is just kind of a vibratory sensation that you can actually palpate. We talked about heave or lifts, which is kind of, you know, if the ventricle has to work really hard to kind of get that systole started, you'll appreciate that on your exam. And then we talked about pulse pressure and how, you know, normally pulse pressure is anywhere from like 25, 30 up to about 40. But once you get above 40, the difference between that systolic and that diastolic pressure, then that is a pathologic condition. You have that increased pulse pressure, which could indicate different types of pathologies, i.e. aortic regurgitation is one thing that would cause that increased pulse pressure. If you have a narrowed pulse pressure where now your systolic and your diastolic blood pressure differences are reduced, you're thinking of a low volume state. So whether it be dehydration or maybe it's hemorrhagic shock, like they're a trauma patient and they're bleeding out, that can lead to a narrowed pulse pressure. Then we talked about how palpating the pulse, it's more than just a single impulse. There's actually a waveform to it. And then we went on, we spent a lot of time talking about auscultation, and we talked about how you have to use the stethoscope, and there's two sides to the stethoscope, and those sides are used to determine or to detect different types of murmurs or heart sounds. We talked about how the diaphragm is used for high pitch. We talked about how the bell is used for low-pitched frequencies. So if you hear something better with the bell, you know that that's a low-pitched frequency heart sound or heart murmur. And we talked about how when you are auscultating and you hear something abnormal, there's three questions you have to ask yourself to help you understand what's going on. First is, where is your stethoscope that you heard this thing best? What's that auscultation site that you heard it best? Then we talked about how you have to know, is this high-pitched or low-pitched? And then we also need to know, is this murmur or is this heart sound present during systole or is it during diastole? And then we went on and we started talking about normal heart sounds. So we talked about S1 and S2, and we talked about how S1 is the lub, which represents the closure of the tricuspid and the mitral valve, right? You should not hear valves open. You should only hear them close. And the S1 gives you a very distinct lub. And it is best heard over the mitral auscultation site because that is over the ventricle area where you're having much higher pressure than you do in the tricuspid area, okay? Then we talked about the dub, or the S2 component, and that represents the closure of the aortic and the pulmonic valves, and it starts diastole, okay? And we talked about how sometimes you can get a splitting of this S2, and it can be physiologic, meaning that it's normal, where you have an early closure of the aortic valve and a later closure of the pulmonic valve due to breathing. And the reason you get that splitting is as you take a deep breath in, you create that negative intrathoracic pressure. You're increasing that venous return, which means I have increased volume and pressure on the right side, which means then I have to maintain a higher pressure for a longer period of time to get that circulation out of the right side of the heart. So that's going to delay, that's going to move the closure of the pulmonic valve over to the right. But at the same time, because I have that negative intrathoracic pressure, the lung vessels, blood vessels, are going to hold on to volume longer than usual. They're more compliant. And that then leads to a reduction in volume going to the left side of the heart. And that will then lead to a premature closure of the aortic valve because you're not able to keep that pressure high enough because you don't have the volume to send that blood out and into the aorta. So that's what splits that S2. But that will change depending on your what phase of the respiratory cycle you're in. So expiration is going to bring those sounds together and you may get a fusion of S2. Then we talked about S3. We talked about how this is a low frequency heart sound, so best heard with the bell of your stethoscope. And we talked about how this is an early diastolic sound, so it happens after the S2. And this is typically present in conditions where there is a excess volume right here, and it's known as the ventricular gallop. compare that to the S4, which is a late diastolic heart sound. It's low frequency, so best heard with the bell of the stethoscope. And this is present when there is a stiff or non-compliant ventricle. So things like left ventricular hypertrophy, where the muscle of the left ventricle is enlarged, it's not going to stretch as much, right? This could also be in the setting of a patient who has had a large heart attack, and now a large portion of that left ventricle has become scar tissue. It's not going to stretch. So what ends up happening is when the atria squeezes right at the very end of diastole, instead of that ventricle stretching and taking all that extra volume, it's going to remain rigid, and now that blood is running into a brick wall. Okay? And that's what the S4 is. And the way you hear this is instead of having a clear, distinct lub dub, it's kind of a bud lub dub. Bud lub dub. We will hear this with the infrared stethoscopes on Friday, and it's much easier to hear that on those than it is here in the classroom. So, if you wanted a table to kind of compare S3, S4, here you go. We talked about ejection clicks. We talked about how these are systolic things. And basically, you hear these, like if you hear like an early systolic click, you're thinking things like aortic stenosis or pulmonic stenosis, where there's a resistance of those valves opening in the beginning part of systole. If you have a mid-systolic, then that typically is attributed to things like mitral valve prolapse, okay? But we talked about opening snaps being a diastolic sound, and we talked about how this might be present in a condition like mitral stenosis, where there is that resistance of that valve opening during diastole, and you get a turbulent blood flow from that. So you kind of get that resistance to opening, it finally opens, you get that snap sound, and then you hear the turbulent blood flow leading to the murmur. And then here's just another a table that kind of compares all those heart sounds. Then we talked about murmurs, and we talked about the three ways you hear a murmur is abnormal blood flow across the normal structure, so conditions like anemia, where you have a reduced volume, the heart's going to compensate by increasing cardiac output. It's going to increase that flow, so you have a physiologic response. But it's still an abnormal blood flow across normal structures. That can lead to a murmur. We also talked about how you can get normal blood flow across an abnormal cardiac structure. So the valve is diseased somehow, and now you are creating a turbulent blood flow across that structure. And then finally, you can have an abnormal shunting of blood. So, for instance, the congenital heart diseases that we talked about, you're having a shunting of blood from right to left or left to right. That going across that shunt, that abnormal shunt, will affect the flow of blood and lead to the sound of a murmur. Then we also talked about how when you go to talk about a murmur, there's lots of things that you can use to describe that murmur to help you with your diagnosis. And these things include, like, when does it occur? Is it during systole, diastole? Is it for the full duration of systole? Or is it present all the time and it's a continuous murmur? We talked about how location radiation is important. So you have your 5 auscultation sites. I definitely would know what murmurs you hear best in those settings, okay? So if I'm listening to the aortic auscultation site or the pulmonic auscultation site, you only hear stenotic murmurs at those sites, okay? And it's going to be, those valves are open during systole, so that means you have aortic or pulmonic stenosis murmurs heard at those locations, depending on which auscultation site you're listening to. I then have to go to Erb's point if I want to hear a diastolic murmur of those valvular diseases. And it's because in aortic regurg and pulmonic regurg, that flow of blood is towards the ventricular septum. And so Erb's point is listening over that ventricular septum, and that's where you're hearing that blood flow going. When we look at the tricuspid and we look at the mitral valve auscultation sites, you can have both holosystolic and diastolic murmurs present there. Just knowing what those valves are supposed to be doing during that phase will help you differentiate a tricuspid stenosis, or if it's diastolic, versus it being tricuspid regurgitation if it is holosystolic. Okay. Now, if you're asking yourself, well, why is it holosystolic instead of systolic? We will talk about it in block 3, so maybe just be satisfied with hitting the I believe button right now. We will talk about it so that you understand the why that's the case, okay? Yeah, so, but we'll work with this in the lab on Friday even more. You do have grading scales for murmurs. Systolic murmurs are not graded the same as diastolic murmurs are. So just knowing systolics are 1 through 6, diastolics are 1 through 4. And by saying this is a 2 out of 6 murmur means something. You can't just throw a number on something. There's a meaning, there's a definition, depending on the grade you give it. Pitch is another thing, that's just high frequency, low frequency. Quality is just kind of how does it sound to you? Is it harsh, blowing, or is it rumbling? The configuration or shape, this is a change of that, how loud that murmur is over time. And you can get things like crescendo where it gets louder, decrescendo where it gets softer. Then we talked about how in some cases you're going to still be questioning what the murmur is, and doing dynamic auscultation maneuvers can help you differentiate the different murmurs. And we talked about how really when you're doing a dynamic auscultation maneuver, we're really just changing the preload and afterload factors. And those are going to impact that murmur. And this was a table to show you what's the expected changes that you're going to see depending on what you're doing with preload, afterload, and how that murmur is present. Okay, we'll go 8 more minutes and then we'll take a break, okay? We will move into our third lecture, which was talking about the imaging or some of the ancillary studies that we can do to help us in the management and diagnosis of our patients, okay? And we talked about, the radiologic studies first, which most common one is going to be your PA and lateral chest x-ray. This is a great study because it can help you rule out things on your differential. It can give you an idea of functional impacts, but it's not going to give you an idea of what the actual function of the heart is, okay? So it is limited with the amount of information you're going to get with that chest x-ray, okay? Then we talked about the cardiac CT, and we talked about how this is a great study for assessing like the anatomy outside of the heart, surrounding the heart, looking at like your great vessels, looking at the pericardium. We talked about how it also is great at analyzing the coronary arteries and looking at calcifications and those kinds of things. And you can get a lot of detail that can help you with risk stratification for a patient with suspected heart disease. And we talked about how, in addition to the advantages, there are limitations because usually you're going to need to do some kind of contrast dye, and the contrast dye that you use in CT scans can affect the renal function. And then there's also concerns for folks who say they're allergic to iodine or shellfish and what this can do to them if you were to give them this contrast dye. But it does not another limitation is it does not assess function of the heart. So I don't get an ejection fraction, I don't get a cardiac output measurement with the CT. When we talk about MRI, this is great at evaluating a lot of the same things that the CT does. The problem is it's a lot more expensive. It takes a lot longer to do the imaging. And it also involves having to do things like slowing the heart rate down to reduce movement artifact. Okay? So there's very limited use of cardiac MRI currently because it's just not better than the other cheaper scans that we can do. But we typically will reserve MRI studies for conditions where we're having to do surgery. It's there for like surgical planning. So really one of the few things that we actually are going to do. One of the advantages are also is you actually do get an ejection fraction from this. Echo is going to be the most common, outside of chest x-ray, echo is going to be the most common imaging study you're going to do. And the reason for this is, and the reason that ultrasound is the primary instrument to really assess function of the heart, is it gives me an internal view of what's going on inside the heart. I can look at the valves, I can analyze their movement and their function very easily. I can also assess the function of the heart in that I get an ejection fraction from it. And I can do all kinds of different like processing of the images to get different information that I need. I can add, like if I'm suspecting somebody has a patent foramen ovale, I can add doing bubble studies to it and get some more information in that way. So I can kind of change some factors to get even more information. And you have two flavors of echoes. You have a transthoracic echo, which is just the probe directly on the chest, minimally invasive, well tolerated. Patient goes in, gets the images done, 30 minutes later they're out the door. You can also do a transesophageal echo, which is more invasive because it involves sedation, but it also involves passing a tube through the esophagus, down into this, or through the esophagus to actually get a better view and window of the heart. And that carries risks associated with it, right? But TEE, the transesophageal echo, gives you much clearer pictures and can give you a very different look of the heart to analyze different structures better, okay? For instance, the left atrial appendage is not well visualized with a transthoracic echo. So if we needed to look at that location, we would do the TEE instead. The other thing is, there's so many different pathologies out there that echo does a great job in assessing, okay? So there's lots of things that we can, lots of information, lots of different disorders or diseases we can diagnose simply by doing an echo. Then we talked about nuclear cardiology studies like the PET scan or the myocardial perfusion scan, where the problem we're having with all the other studies that we've talked about is we get a general idea of function of the heart, we get general ideas of what the plumbing looks like to the heart, but we actually don't see a direct impact of that perfusion, the flow through the plumbing. So by doing this study, we can actually see how that blood flow gets access to the myocardium and how it perfuses. So now we get a perfusion answer. And then we talked about how the other aspect is we want to analyze the conductive pathways of the heart, because as you learn in EKG, the conductive pathways are vitally important for the function of the heart. And the limitation we have with the EKG is it's 10 seconds in time. What are the chances that I'm going to catch an arrhythmia in that 10 seconds, especially if they're asymptomatic? So we have to have additional studies to help us with determining and diagnosing these arrhythmias. And these could be your Holter monitor, which is 24, 48 hours that you're wearing, this EKG. Or you can do a Zio patch, which gives you 2 weeks, maybe even 30 days of information to try to capture this arrhythmia. Okay? So Holter and Zio patch help you with that. But all of these tests that we talked about are done at rest, which cardiac disease a lot of times is not visible until you are in a stress response or you're exerting yourself, right? So there's a stress test version of all of those tests that actually now induces a stress on the heart, and now we're analyzing the differences of function, activity, all that with exertion. And one of the most common ones is this graded exercise treadmill stress test, where the patient's wearing an EKG, they run on the treadmill, and then we watch for the change in EKG based on that exertion and that stress, okay? And that will give me an idea if I start to see ST elevations, ST depressions, T wave inversions. That shows me that the perfusion in that area is maybe not adequate to meet the stress demand. Okay, so that's what a exercise treadmill stress test is looking for. That brings us to 10:50. So let's go ahead, take 10 minutes, we'll come back and finish up.
Good old, yeah. That's trying to do it. So I was doing it myself. If you just do 43 slides a day, you'll have it, like if you just try to memorize these 4 slides per day, it'll be good. And then that last day, just memorize it. Like just going over it. Do a little.
So during this time,
I think
There would be a different graph. This is which is an estimate of right. That's what yes.
But those are two different things.
Yeah, this way doesn't
so the market guidance is like it's
Because he's saying, that's why I was saying that, that's why I was saying that we're using diastole
well,
too generically. Yeah.
unless you happen to get so really the treatment
They really. Definitely not good. It's a statistic.
Yeah.
How do you like spot it? Slightly.
I don't already know. It's called chess. It's chess, dude. I was nice. I'm like, how'd you study? I was like, dude, I just studied on the last day before the test.
You're gonna have a medic that's gonna come here for advice. You gotta go through 5 steps. And then we should study like 5 hours a day, 7 hours like that. Study
Wait.
4 hours. Work for me, it's gonna work for you.
Don't even listen to like play chess, dude. You're fine. You're fucking fine. Anybody tells a difference, fuck. Just try hard.
This itself, that has been the whole lecture.
Look at all of them.
Get rid of that gym membership. I wonder how deep this is gonna go into. So, I only really need to get started. Feeling well. Feeling off is pretty nice to get adjusted. You don't know. The thing is, so I lost at least 80 pounds. Like, it's they're spending like $1,000.
So the maximum gets
40 years. But use a treadmill or a bike. So you gotta have some cardio. Because I was like, the house heard of that. I can't leave the house. I'll be back in 5 minutes.
yeah.
Yeah, I could. 30 seconds, and after that, I gotta do a bunch of push-ups.
You only get one question per yeah.
Like, lately I've done that.
Alrighty, we got 11 o'clock on the clock, so let's get back to it. so we can get through this. We talked about the exercise treadmill stress tests, and this looks at the EKG changes. We can do a stress echo, where now either we have them exercise on a treadmill, have them run around the hospital for a bit, or I give them a chemical or a shot of like dobutamine in order to induce a chemical stress to the heart. And then I do an echo to look at and analyze the functional differences of the heart between rest and exertion. But one of the big things is going to be your myocardial perfusion scan, because great, you get images of what the perfusion looks like into the myocardium at rest, but when somebody has a STEMI, it's typically is like during exertion, right? And you can actually then compare what the difference of the perfusion is at rest versus exertion. And this will allow you to diagnose a patient who has either a pending heart attack that you can then intervene before you actually have true cell death. Okay. Then we talked about the laboratory studies. We said, we showed a chart that there's so many out there that you can order that are, analyze the cardiac system. But we talked about how this list is really the only ones that we're going to talk about in this course. Okay, so just knowing which laboratory tests we have and what answers it can give to you will be important, and we'll throw these out at various points in our lectures to talk about how to diagnose the different diseases. So that was non-invasive testing. Then we talk about how you have invasive testing, which means there's risks, increased risks associated with these testings. And the first invasive test that we talked about was cardiac catheterization, where I am threading wires into very delicate blood vessels. And I can get information, like diagnostic information, but if I'm doing the left-sided, I can actually do therapeutic things as well. So cardiac catheterization is usually there for high-risk patients, or if we are expecting to have to do a procedure to fix a problem. Left heart catheterization is probably one of the most common ones you're going to get, because it can be both a diagnostic and a therapeutic tool. And the way we do a left heart catheterization is I have to cannulate, or I need to place a wire through an artery, i.e. femoral, brachial, or axillary artery, thread those wires up through the aortic arch, and then access either the left ventricle, or if I'm looking at like the coronary arteries, I'm going to access the coronary arteries with those wires. Okay, so imagine the risk of threading these wires through delicate blood vessels. And there's so many things that you can use a left heart cath to diagnose, but there's so many different things that you can also use a left heart cath to treat. So if I have a occluded coronary artery, I could do what's called an angioplasty, which is just a balloon inflation to kind of pop open that lumen a little bit. I can also put a stent in instead, where now I've got this cage-like structure to maintain the opening of that vessel. And then there's other things like valvular diseases that I can treat with doing this catheterization. When we talk about right heart catheterization, we do this by accessing a vein to get to the right side of the heart. And the right side or right heart catheterization is really there for like monitoring and diagnosing. There's not a true therapeutic benefit to right heart catheterization. Okay, so the most common form of this is a patient who is critically ill in the ICU who requires pretty complex and invasive monitoring to kind of regulate their physiology and their hemodynamics. And you can kind of see all of the things that can help you with diagnostic stuff. But there are complications, regardless of this being left or a right heart cath. There are complications that could develop that can lead to pretty significant morbidity and mortality. So this is why we don't do these tests on everybody who's getting a cardiac workup, okay? Sure, the cardiologists would like it for their wallets, but there is some disadvantages to our patients unless they are high risk. Then we talked about an electrophysiologic study where basically we access the right side of the heart, we place these wires, and we can interrogate the conduction system. So if I have a patient who has an arrhythmia that comes and goes, I can do this study to diagnose the condition. Okay, I can see where like this short circuit might be. I can isolate it, and then I can get rid of it with like an ablation type of procedure. Okay, and then that will treat the condition, that recurrent arrhythmia, treat it so that this patient won't have this happen to them again. Okay. That was lecture 3. Questions on lecture 3? 4-2. All right. So we went on to lecture 4 and we talked about infective endocarditis, and we talked about how this is a condition where there's like an inflammatory process that can really affect any structure that has endocardium. Okay. And we talked about how there are certain things that could put somebody at a high risk or higher risk of developing this condition. And we talked about how there's a couple of different ways to describe or classify this infective endocarditis. And basically the way that we describe this or classify it kind of helps us determine what's the most likely cause of that infective endocarditis. Is it a staphylococcal infection? Is it a streptococcal infection? Is it an IV drug user who could get really anything to include Pseudomonas or even fungal? Okay. So this helps me with the diagnosis or or have an idea of the most likely cause so that I know how to treat it while I am waiting for my lab results to tell me exactly what's going on in the patient. And we talked about how it's a rare condition in the United States, but there are 10 to 15,000 cases a year. And the most common person who's going to be at risk of this is going to be your elderly male type patients, ages 60, because they have some kind of cardiac disease. But in the setting of IV drug users, that age is no longer in the 60s, it's more in like mid-30s, because that's the age group that typically is doing IV drugs, right? Usually we think of as you get older as an adult, you're not doing IV drugs, but that's a stereotype. So don't limit that to you. If you have somebody who's 80 years old who looks like they have IV drug use, then be thinking it's that, right? Okay. So don't apply the stereotype to your individual patient necessarily. Other risk factors that are associated with this, so we said if you have any kind of valvular disease or you've had a replacement of one of your valves, you have a prosthetic valve, if you have a congenital heart disease, that puts you at higher risk. If you have poor dental care, if you have dental abscesses or anything like that, this is the most common way somebody develops infective endocarditis in the United States, is the dental care. Because there's an easy access of that bacteria in the mouth to get into the bloodstream and cause this. When we talk about infective endocarditis, it's more than just bacteria enters the bloodstream. If it was, we would have so many more cases of this because we have so many more patients who present with sepsis, okay? So there's 4 steps kind of to the development of this condition. The first is you have to have some kind of damage to the endocardial surface. And that could be a prosthetic valve, right? So you have to have that damage to the endocardial surface. That has to then trigger kind of a blood clot or an inflammatory reaction to try to heal that damage. And then, as that process is going on, you happen to have bacteria in the blood that then gains access to that blood clot inflammatory process, which then creates this very complex structure called the vegetation, where now that bacteria has, one, the substrates to consume and reproduce and grow, but then also it serves as a protective barrier from antibiotics that you might want to give to that patient to treat this infection, okay? And that vegetation then can interfere with the function of the heart structure that it's attached to, i.e., if you have it on the valves or one of the valves, it can interfere with the function of that valve. The way we diagnose infective endocarditis is by using the Dukes criteria, or modified Dukes criteria, where I don't expect you to memorize the components of it, but just know this part to it. So what do I need to see in order to diagnose and say that this is definitive infective endocarditis? What do I need if it's possible? And then basically, if you don't meet those two criteria, then it's rejected and cannot be infective endocarditis, okay? So don't memorize the components, just memorize that you need 2 major, or 1 major, 3 minor, or 5 minors to be able to say that you have a definite infective endocarditis. How are we going to other things to help you with the diagnosis? So yes, your history is going to be important, your physical is going to be important. Definitely focus in on substance abuse history, because if this is an IV drug user, then I'm going to be having to manage them very differently because they tend to have more aggressive kind of bacteria, and also they have different complications associated with them. If you have a patient who has a new cardiac murmur and a fever, you must be thinking of this as the initial thing on your diagnosis, or the top thing on your differential. You've got to be thinking infective endocarditis. Okay. And the reason for that is the 2 most common presenting symptoms of infective endocarditis is a fever with a new murmur. Okay. The things that we normally think are pathognomonic, so things that we think of definitely will diagnose this condition, they are rarely actually even present in infective endocarditis. You can see is what 2 to 15% of patients actually will have the Osler nodes or the Janeway lesions or the Rot spots and those types of things. So fever with a new murmur, be concerned for infective endocarditis. But fever, it's a vague symptom, right? The patient's not going to tell you that they have a new murmur, right? They're not necessarily going to hear it. So it could be that the initial symptoms that prompt them to come to see you is actually going to be a complication that develops from the condition. And it could be a central nervous thing. So part of that vegetation breaks off, goes to the central nervous system circulation, causes a stroke. Okay? It could be they go into renal failure because of this. It could be that they start developing bone pain because that vegetation is breaking off and gaining access to the bones and starts kind of eating away at the bones, and now you're feeling pain, bone pain from that. So it could be that the presenting symptoms are actually a complication of this condition. What should you do? Well, we need blood cultures. Preferably get blood cultures before you give them any kind of antibiotics, because you want to get that culture and that sensitivity. You want to know what the bacteria exactly is, and you want to know what that bacteria is sensitive to so you can tailor your antibiotics to what should work for that patient. Then there are the other blood tests you're going to want to do. You want to get a CBC, check their white count. You're going to want to get a basic metabolic panel because you want to assess the function of the kidneys, because this condition can affect the function of the kidneys, which can also then affect your antibiotic regimen, because maybe your kidney function's not great enough to take that antibiotic, or maybe we need to change the dosage of that antibiotic based on that. You need to get an echo because you want to visualize that vegetation. And you can start off with a transthoracic echo and see if you can see it on the transthoracic. minimally invasive. These patients tend to be pretty sick, so can they tolerate sedation to do a transesophageal? So try with the transthoracic first. If you don't see a vegetation, then do follow up with the transesophageal echo to see if you can see it that way. Then we talked about, the symptoms or signs that you may have that kind of are more indicative of this, or a little more specific for this condition. And we talked about how you can have vascular phenomenon and you can have immunologic phenomenon. And examples of vascular phenomenon are going to be your Janeway lesions, which are painless erythematous spots. You can have splinter hemorrhages, where you're kind of having like this occlusion of like the tiny capillaries in like the fingernail beds or the toenail beds. You can have septic cavitary lesions, especially if you have somebody who has right-sided infective endocarditis, i.e. somebody who's like an IV drug user. You may get these septic cavitary lesions. You may have immunologic phenomenon where it can affect the retina and you get these Roth spots, which you can kind of see like right here. It's got that central clearing with like a halo appearance around it. You can have Osler nodes, which are painful lesions. And then on your other ancillary studies, chest x-ray may not be great, may not be helpful at all. EKG may be completely normal, but if it is invading like the ventricular septum, it could be impacting the conductive pathways, which then could lead to arrhythmias developing. Your labs, like a urinalysis, can show that if there's kidney function concerns, and then your CBC we talked about as well. But it typically takes 24 to 48 hours to get any kind of information from cultures that you do. So how do you know which antibiotic regimen you should put them on? And that comes from the risk factors. What is the suspected etiology of this infective endocarditis? And let me target, based on those risk factors, the most likely cause or the most likely bacteria that they have. So IV drug users, okay, be thinking bad bugs. So things that cover MRSA would be important. Even things like Pseudomonas in Candida should be covered early on while you wait for those culture results to come. If you have like an older patient with a native valve, so they have their own, like the valves they were born with, typically we think of more of a dental source for this, so strep viridans is the most likely bacteria causing it. If it's hospital acquired, you gotta be thinking MRSA. If you have prosthetic valves, be thinking of like staph epidermidis. If you have strep gadalyticus or strep bovis, it's also known as, be thinking of actually this patient has colon cancer and they probably should get a colonoscopy before they are discharged from the hospital. When these patients are gonna be admitted because they are gonna be very sick, that carries a high mortality rate. So while you're waiting for blood culture results to come, you are treating them with antibiotics. To help you manage these patients, you're going to want an infectious disease specialist to be helping you with that. You're going to want a cardiologist on board to help you with managing this patient. And you definitely are going to want a cardiothoracic surgeon to weigh in on whether they think surgery is necessary or not, because they are the only entity that can give you that source control that you need in order to treat this infection. Antibiotic regimens are going to be prolonged, so we're talking about at least 4 to 6 weeks of IV antibiotics, because you got to get all of that bacteria for any part of the vegetation that may persist. You want to make sure you get rid of all of that bacteria so that it doesn't come back, it doesn't recur. Okay? But even after they start treatment, they're not out of the woods. Because as that vegetation is there, it becomes fragile, and you have a lot of shear force as of blood circulating in and through the heart, right? they run the risk of having portions of that vegetation chip off, break off, and get sent downstream, and it can go anywhere in the body and cause additional complications or problems. Even after antibiotics and getting a great antibiotic regimen, they still are not out of the woods, because the relapse, if they were to have a relapse, experience a relapse, could occur within 2 months. And this carries a high mortality rate. So 20-25% of patients are going to die in the hospital from this condition. The mortality rate is a little worse at 6 months. 50% mortality if they have fungal or pseudomonas, so you're thinking of like your IV drug users, right? And then if you don't diagnose this and you don't treat this quick enough or early enough, then they run the risk of having 100% mortality. They will not spontaneously recover from this condition. But then this brings us to the additional topic of, okay, this is a bad disease. How do we know, or who should we be concerned about and get antibiotics to prevent this from happening either in the first place or happening again if they've already had it once? So there's certain criteria that if they have any of these conditions, if they get a high-risk procedure, which typically we think of high-risk procedures or dental procedures where they're manipulating the gum tissue, if they're going to get any procedure like that, then they should be put on prophylactic antibiotics to reduce the chance and risk of developing this condition. And typically all you need to give them is 2 grams of amoxicillin, and it could be PO if they can tolerate oral meds. If they are allergic to penicillins, then you're looking at more like cephalexin or a macrolide to serve as that prophylactic regimen. Okay. Questions on infective endocrinitis? Okay. Congenital heart disease. So we talked about the differences in fetal circulation and in an adult circulation. We talked about where oxygenation occurs, and we talked about how the right side of the heart actually handles oxygenated blood coming back from the placenta. And we talked about how congenital heart disease is actually the most common congenital disease a kid may experience. And of the congenital heart diseases, the ventricular septal defect is the most common one that you're going to find. And we talked about the reason congenital heart diseases develop is it could be, unfortunately, bad luck. You just kind of had a developmental error that occurs. It may be genetics, whether it be inherited, like everybody in the family has this condition. It could be a spontaneous mutation that occurs where an amino acid is changed and that leads to development changes. It could be environmental exposure, so maternal exposures. So while the mom is pregnant, they get exposed to, you're just thinking excess alcohol or even rubella. That can then lead to congenital changes. And rubella is a great example because one of the things you find in rubella syndrome is a patent ductus arteriosus. Okay? And then there's also, if the mother has other medical conditions that could impact kind of that environment for growth and development. Okay? So poorly controlled diabetes, I have all this extra sugar circulating around. I have hypertension, which now impacts the amount of blood flow coming to the placenta. If I have thyroid disorders, thyroid disorders can impact any organ system, but it can also impact and regulate how that baby develops in utero. Then we talked about the development of like the atrial septum. We talked about how initially you just have this kind of this hollow structure, but we need it to be a distinct circulation of right and left, right? We also talked about how because of the changes in fetal circulation and how the physiology is a little different, we need some compensatory things or some bypasses kind of built into this structure to make the fetal heart more efficient, okay? So the way this develops is you initially have the initial hole, so ostium primum, ostium being whole, primum being one, or first. You have that. But that's not conducive for living an adult life, right? Or after birth kind of life. So you start to get this septum primum, so septum being, kind of think of it as a wall, primum being first. This first wall starts to develop. And then it starts to occlude and separate left and right. But I need to have that bypass built into this system. So you get a little reabsorption of the septum primum, and it causes the development of the ostium whole secundum, second hole. Now, I don't want that hole to be permanent because I don't want that unregulated right to left shunting or left to right. So then you get this septum, so this wall, secundum, second wall, starts to develop, and it kind of overlaps to the point where now you have this one-way little flapper valve that will only open when the pressure on the right atria is higher than it is on the left atria, which is what happens during when the baby is in utero. Now, if that whole development is disrupted for some reason, and either that ostium secundum is too big, then it can lead to the development of an atrial septal defect, where now you have this pathway between the right, or this communication between the right and the left atria. Now, typically after birth, you have a higher pressure on the left atria than you do on the right atria. So that shunt is going to be from the left atria to the right atria, and that's going to trigger the mixing of oxygenated blood with deoxygenated blood on the right side, which then will get circulated back up to the lungs. But it's already oxygenated, so it can't get re-oxygenated. And that then can lead to pressures increasing in the pulmonary arterial system because of that increased volume, increased pressure. Okay. Most small ASDs don't cause any symptoms. When we talk about management, a lot of times we don't need to do anything to treat these because they heal on their own or they correct themselves. But if a patient has an atrial septal defect and it persists into adulthood, it can then cause compensatory changes to include pulmonary hypertension, which then can lead to problems down the road. Large ASDs, so if a baby is born with a large ASD, they could present with heart failure symptoms early on, which then could lead to death if it's not treated or managed appropriately and quickly enough. What are you going to see on physical exam? So kind of the big thing is going to be your murmur, okay? Typically you're going to hear this fixed split S2, which is technically not a true murmur, but every standardized test, if you see fixed split S2, be thinking atrial septal defect, okay? EKG may be normal, may have some compensatory changes on it, like right axis deviation or right ventricular hypertrophy. Chest X-ray may be normal. You may have prominent pulmonary arteries depending on how much volume is coming through. Echo is going to be your test of choice because you're going to see that defect and you're going to know the degree of shunting and all the other secondary effects of having that shunt there. So echo is going to be your study of choice if you suspect an atrial septal defect. Treatment, fortunately, most, especially if they are less than 6 millimeters, they tend to spontaneously close by the age of 2, so we don't need to do anything. If they're larger than 6 millimeters, say like 8 millimeters, then there's a concern that this is going to be persistent and it may need a surgery to fix it. Other reasons that would require surgery to fix it early on is if they have severe, moderate to severe type of symptoms related to that defect. But then we talked about patent foramen ovale, which kind of think of patent foramen ovale as a atrial septal defect, but it is not an atrial septal defect because there's technically not a defect. It's just that bypass that we had in fetal circulation persists. That bypass should have scarred up and healed by like 6 months of age, so you shouldn't have this one-way or this little one-way flapper valve present in an older child or an adult. But in some patients, it persists. And the problem with the patent foramen ovale is if this patient develops a condition where now the pressure in the right atria exceeds the pressure of the left atria, now you're having flow going across that foramen ovale. Which is bad enough, but let's throw in one of the more common causes of that right atria increasing, i.e. a blood clot that comes from, say, the lower extremities. That gets into the right atria, causes that rapid increase in pressure of the right atria. It causes that foramen ovale to open, and now that blood clot can then get over into the left atria and enter the left circulation. Instead of being filtered out by the lungs, it now is in that left circulation, and it can cause embolic disease such as a stroke. So normally, if you have a patient who otherwise is low risk for a stroke, like their 20s or 30-year-olds who suddenly have a thrombotic stroke, you've got to be thinking of a patent foramen ovale. And you need to diagnose it because you're going to need to do surgery to fix it. Okay. And the way you can diagnose it is you do that echocardiogram, but let me do that bubble study part to it, where I inject rapidly an agitated saline that creates bubbles. I then will increase that pressure in the right atria, and it will open that valve, and you'll see those bubbles get over into the left atria. Okay? So that's how and why you do a bubble study. Then we moved on, we talked about ventricular septal defect, and we talked about how this is the most common congenital heart disease you're going to see in your patients. And we also talked about how, fortunately, the vast majority of these will heal on their own. What happens in a ventricular septal defect, because in the normal heart, that pressure on the left side is higher than it is on the right, you're going to have blood shunting from left to right. So oxygenated blood is going to move over to the right side and mix with the deoxygenated blood. These patients tend to be acyanotic with this. But the problem is, if this persists for decades, it can cause some compensatory changes and can lead to the development of Eisenmenger syndrome, which now creates a acyanotic lesion and makes it a cyanotic lesion. Okay. And we'll talk about in a couple of slides why that happens. But on exam, big thing to know is you get this harsh holosystolic murmur, best heard in the left lower sternal border. Small defects have loud murmurs, so that also is the reverse is true too, where large defects tend to have soft murmurs. Okay. Chest X-ray may be normal, may not be helpful. EKG may be normal, may not be helpful. There may be some compensatory changes that you'll detect on it, but it's not necessarily specific to a ventricular septal defect. Echo is going to be your test of choice because you can visualize the defect, you can measure that shunt, and you can also then appreciate the impacts, the secondary impacts of having that there. And then we said the majority of these are going to heal on their own, but if it persists or they're having severe symptoms related to it, we may need to go in and do a surgery to fix that hole. Because the concern is that if you let this persist for an extended period of time, they can develop Eisenmenger syndrome, which is you develop a higher pressure in the pulmonary arterial system, which then leads to a higher pressure in the right ventricle. And if that pressure in the right ventricle exceeds the pressure in the left ventricle, you now reverse that shunt, and now blood goes from the right deoxygenated blood into the left oxygenated blood. They mix, and now you're having deoxygenated blood being sent up through the artery or the aorta through the peripheral arteries. So now you're causing a cyanotic condition. And the best way to treat this is to prevent it from happening in the first place. So if you have a patient who has an identified congenital heart disease that is not healing on its own, then they need surgery to fix it. Because once they develop Eisenmenger syndrome, it is exceedingly difficult to correct this condition. That then leads us to patent ductus arteriosus. So the ductus arteriosus was one of the bypasses that the fetal heart had in order to get blood to bypass the lungs that was already oxygenated to the aorta and down to the peripheral arterial system. Most commonly found in like premature babies. That's because typically what causes this structure to go away is that prostaglandin levels start to drop. And when that prostaglandin level drops, it causes the closure of this ductus arteriosus. But if I have a premature baby, that regulation of the prostaglandin levels is going to be impacted, so you don't get that drop in prostaglandin, and now that ductus arteriosus is allowed to persist. And the problem we have with this condition after birth is the pressure in the aorta is higher than the pressure in the pulmonary arteries, and now you have a bypass of oxygenated blood from the aorta going down into the pulmonary arteries, but it's already oxygenated. So now you have an increased volume, increased pressure in the pulmonary arteries, which then can lead to pulmonary hypertension, and then lead to heart failure and all that kind of stuff. Problem is, with that increased pressure in the pulmonary arteries, if you allow it to persist for years, decades and stuff, they can develop that pulmonary hypertension, which then can lead to Eisenmenger syndrome, where now, instead of that shunting occurring inside of the heart, now it's outside of the heart, and what you get now is a reversal of flow where that deoxygenated blood in the pulmonary artery gets shunted to the aorta and mixes with the oxygenated blood in the descending aorta. So this happens after the arch. So upper body is going to be acyanotic because it's getting that oxygen-rich blood. But the lower body, the lower extremities are going to get that deoxygenated blood, and that's going to be problematic. And other things that you might find is, okay, if it's a small PDA, maybe asymptomatic. Larger PDAs may have like that heart failure that's present. On physical exam, this continuous machine-like murmur is the description you're going to see on all of your tests for patent ductus arteriosus. So if you see continuous machine-like murmur, be thinking PDA. EKG may not be helpful, chest x-ray may not be helpful, echocardiogram is going to be your test of choice because you're going to see that patent ductus arteriosus. If you have as far as treatment goes, if you have a preterm infant where that prostaglandin level regulation is a problem, you can actually give them an NSAID, like ibuprofen, and it will drop that prostaglandin level and then cause the closure of this ductus arteriosus. But if you have an older infant or maybe it's an adolescent or adult that you're diagnosing this in, then you're going to have to do a surgery to go in and remove this, or you can do an embolization where you're shooting coils via catheters into this area, and then it kind of clots off and blocks flow. Then we talk about coarctation of the aorta and how you can see this in patients with like Turner syndrome or 45XO, and how you get this narrowing of the aorta, which then can cause blood flow problems down into the lower body and into the lower extremities. So the blood has to find a way to get around that narrowing, and unfortunately it tends to go up to the upper extremities, up into even the central nervous system, which then can cause some problems. But mild coarctation may be completely asymptomatic. They may have things like headaches or bloody noses, so very non-specific kind of symptoms. You may have differential cyanosis, where the upper extremities are well oxygenated and perfused, but the lower body is cyanotic because you're just not getting blood flow or adequate blood flow down there. The biggest thing you're going to see is systemic hypertension, and this is like your kiddos who come in and their blood pressure is elevated. So if you have a kid, a teenager, adolescent who has blood pressure, be thinking about this, okay? But if you wanted to do a physical exam to diagnose it, then typically you have this infrascapular murmur. It's going to tell you, let you know that they have this condition. EKG, chest x-ray, may have some non-specific kind of findings. You may see notching of the inferior surfaces of the posterior ribs because of that. Those arteries are getting larger volumes of blood. They start to kind of get enlarged, which then kind of eats away at the under surfaces of the ribs. Your echo is going to be your test of choice because you're going to see and be able to see that narrowing, and then also measure the effects of how much blood flow is actually getting past that narrowing and how much is not. Treatment, if you have a young kid with this, actually give them prostaglandins because you want to keep that PDA open, so you're kind of having an off valve from this. But a lot of times you have to go in and either do a balloon to kind of open that up, pop it open, or you have to just remove the diseased area and then suture the two ends together. And then, because this is a congenital heart disease, typically they get antibiotic prophylaxis for infective endocarditis while they have this condition and up to 6 months after repair. Then we talked about cyanotic lesions, and there's only 2 cyanotic lesions that we talked about. We talked about tetralogy of Fallot, where tetra meaning 4, you've got 4 things that develop that cause some physiologic changes. We talked about how really this all comes down to there's this abnormal anterior encephalad, so towards the head, kind of displacement of the infundibular portion of the interventricular septum. So this thing here is anterior and kind of distorted cephalad. And it causes these 4 problems that you see in tetralogy of Fallot. It's the most common cyanotic heart defect, but it's not the most common congenital heart defect. It does have a genetic component, so DeGeorge syndrome, which is a microdeletion of chromosome 22, can put somebody at high risk of having this condition. And we talked about how the physiologic effects of this is you have deoxygenated blood. Path of least resistance is to go through the aorta as opposed through this narrowed pulmonary artery or pulmonary valve into the pulmonary artery. So you're having that mixing of deoxygenated blood with oxygenated blood there on the right. And this can lead to TET spells where if babies are feeding or babies are crying, it can actually make this cyanosis worse. In addition to the cyanosis, you may have this systolic ejection murmur similar to like a pulmonic stenosis. You may have this VSD murmur present there. So not necessarily like specific findings of tetralogy, but some of the other impacts of having a condition. On chest x-ray, you may see this boot-shaped heart. Echo is going to be your test of choice because you're going to be able to visualize that defect. And we talked about, for as far as treatment goes, one of the things that patients with tetralogy have found is if they squat or bring their knees to their chest, the cyanosis gets better. And the reason for this, the physiologic reason for this is it increases your afterload, So now you have a higher pressure on the left, which will then translate over to the right, which hopefully with that increase in pressure on the left and into the right will cause the flow of blood from the right ventricle past that narrowing or that obstruction to gain access to the pulmonary artery so that that blood can then become oxygenated and then return to the left side of the heart oxygenated. So it's an afterload thing that they're doing that's kind of distorting or changing that physiologic condition. Patients typically are going to need surgery to fix this problem. If they get surgery done, one, the survival rate's pretty good, especially the younger they are, but the prognosis is very good. So at 25 years after surgery, 90% of patients with tetralogy of flow that are adequately treated with surgery will still be alive. There are some complications and some surveillance things that you got to do for them, but surgery is truly the treatment for this, and they tend to do pretty well with it. Then we talked about transposition of the great arteries, and we talked about how basically the aorta outflow and the pulmonary artery outflow are just swapped. So now you have two distinct circuits where you have the deoxygenated blood coming up from the veins that are then sent out from the right ventricle into the aorta, so that never becomes oxygenated. And then we talked about the other circuit is the left side, where you have blood coming back to the left side via the pulmonary arteries, but then the outflow of the left ventricle is the pulmonary, you have the blood coming back from the pulmonary veins, and the outflow of the left ventricle is the pulmonary artery. So you already are then sending oxygenated blood back up to the lungs to not get oxygenated again. So you can imagine this circulation is okay in utero, right? Because that oxygenation is occurring at the placenta, so you're just circulating oxygenated blood to the systemic arterial system kind of in a more direct fashion, right? But when the baby is born, this will quickly become deadly if it's not treated properly. And these are going to be cyanotic babies, and your diagnostic tests may show things like this egg on a string or whatever on the chest x-ray, but the treatment is going to be ultimately a surgery of some sort. But in the meantime, while we're waiting to either transfer the patient to an area that can do the surgery, or while we're waiting to get into the operating room, we can actually give them alloprostadil, or this prostaglandin E1, to keep that prostaglandin levels high, to keep that ductus arteriosus patent. Okay? So that way we at least get some mixing of oxygenated blood in with the deoxygenated blood. Okay? And then ultimately, we can either just do this atrial switch procedure that you see down here, where I kind of put all this fancy tubing in to redirect the flow of blood, or I just go in and I just remove those great vessels and move them where they should be attached to. Okay. And then we talked about these yesterday, which we only have like 2 minutes, but knowing kind of some possible etiologies of acute pericarditis, knowing the physical exam findings for acute pericarditis, like that positional chest pain, is important. Knowing the EKG changes that you might find on a patient with acute pericarditis will be important as well. I'm not going to ask you to analyze a EKG on this test, but I might show you one that shows you diffuse ST elevations, i.e. this patient has acute pericarditis kind of thing. Okay. Then big thing to know is the treatment. So in a patient who does not have MI or heart attack-induced pericarditis, the treatment is an NSAID plus colchicine, okay? And it could be any NSAID. But if you have it post-MI, then it's aspirin plus colchicine. And that's your only thing that you can do. Like you see here on this one. And then pericardial effusions we talked about, where you just have that excess fluid. Lots of things can cause it, including viruses. No Ewart sign on diagnosing it, and then also just be aware of some of the secondary effects of having a pericardial effusion. Know that on EKG they see this electrical alternans, so this difference in amplitude from one QRS to the next. Treatment, if it's moderate to severe, you're going to stick a needle in that fluid and draw it off. Then we talked about cardiac tamponade, and now it's basically that effusion is now too much, and exerting too much of a pressure that's now impacting the actual function of the heart. And we, as far as etiologies go, we talked about how now you have trauma that you can add to it. And then we talked about Beck's triad as a physical exam finding for cardiac tamponade, where you have hypotension, JVD, and muffled heart sounds. We talked about electrical alternans on the EKG. We talked about the way we treat it is you got to stick a needle in there, get off all that fluid to kind of take off that pressure, that inward pressure on the heart, so that you can restore function to the heart. And then we talked about constricted pericarditis as a secondary chronic thing from other conditions, i.e. things like post-viral syndrome or other things that cause this chronic inflammation. We talked about how this is a diastolic problem, so there's a filling problem to the heart in this condition. Kussmaul's sign is seen with this. Talk about doing echocardiogram and actually seeing that thickening and everything like that. We talked about the prominent Y descent. And we talked about how the only way to treat it is you got to do surgery, and typically you're going to be doing a full pericardiectomy, where you're going to be removing the entire pericardium to kind of restore that function. So, yeah, and then we finished up with myocarditis and all that. Questions? Now, that was a whirlwind of information, but studying these slides will definitely help you with the test. Okay. I'll see you all Friday.